Good afternoon, everyone. Today's topic of discussion will be recurrent pneumonia in children. It's a case-based approach. I will be giving a brief introduction on recurrent pneumonia. Then we'll go through some case scenarios. I have some 8 to 9 case scenarios. We'll discuss each case scenario for around 5 minutes, and then conclusion for the last 5-10 minutes, and we can take some question and answer session in the last 10 minutes. So I think we could start with the presentation. So on an average, every child worldwide suffer 4 to 8 minor respiratory tract infections in a year. So what I mean by respiratory tract infections known as ARI, acute respiratory tract infections, which may be an upper or a lower respiratory tract infection. So the recurrent pneumonia is most common referral to a pediatric pulmonologist. The incidence is, there is no fixed incidence, but it varies between different populations, and worldwide the incidence is varying. It ranges from 4 to 7%. The incidence is still unclear. Third question which is always in the mind is whether it is really a recurrent pneumonia, whether it is just an upper respiratory tract infection or it is just a lower respiratory tract infection, what we tell as an LRI, or it is really a pneumonia. This is the most common referral to a respiratory specialist. So moving on to some little basics before we proceed to what is recurrent pneumonia is. Just want to know the WHO classification of pneumonia. So any child with fever, cough, fast breathing and chest in drawing. Fever, cough, fast breathing with or without chest in drawing would be classified as having pneumonia. Obviously, the inclusion of an X-ray is not in the WHO criteria, but any child who is sick would definitely would have taken an X-ray or would been referred to you with an X-ray on hand. So once we have a clinical scenario of a pneumonia, we look for warning signs and we triage them accordingly, whether they are going to be treated as OPD wise, inpatient, or to an high dependency or intensive care unit. So moving on to some basic definitions of recurrent pneumonia. So how will you define recurrent pneumonia? Recurrent pneumonia is defined as whenever there is 2 or more episodes of pneumonia in a year, in 1 year. Whenever there is 3 episodes in a lifetime or ever, with radiological clearance of the shadows in between the episodes. So this is the current definition of recurrent pneumonia. This is different from another confusing term. It's known as persistent pneumonia. Persistent pneumonia is nothing but whenever there is clinical plus radiological persistence of pneumonia, with ranging from more than 4 weeks to 12 weeks. The minimum cutoff period is 4 to 6 weeks, because some infections, for example, the RSV infection or the influenza infection, can have a radiological clearance to take time to clear for more than 4 weeks. The cutoff range is given for 12 weeks, particularly with response to studies done for adenoviral infections, where they found out that adenoviral pneumonia takes place, the resolution radiologically at least takes place close to 8 to 12 weeks. However, there should be adequate and appropriate therapy to fit into this criteria. So this is the basic definitions of a recurrent pneumonia and persistent pneumonia. I wouldn't be covering on persistent pneumonia in this talk. There are plenty of overlaps, but the cause of a persistent pneumonia all overlaps with recurrent pneumonia. We will be dealing mainly with recurrent pneumonia in this talk. Now, most important is right from our undergraduate days, the most important thing which all of us have been taught is history. So how to take and elicit a good history. So the first thing which you do is take a good antenatal, postnatal and age of the presentation. Whether the baby is a term baby, preterm, with a mechanism status, it gives an important clue to chronic lung disease or cystic fibrosis. The growth, by maintaining the charts, tells about the chronicity of the problem, particularly about primary immunodeficiencies. Development and immunization will tell about whether there is any oromotor issues. You have to calculate the development quotient, and immunization, particularly with regards to tuberculosis and respiratory vaccines like influenza and pneumococcal vaccines. What is commonly missed is the feeding history. The pattern, duration, and cough during feeding gives an important clue to oromotor disturbances. Medication history is also very, very important because child might be on immunosuppressive drugs due to an undergoing BMT or a transplantation. They can have secondary immunosuppression, and that leads to pneumonia. Family history of lung disease and death and gives an important clue about genetic pattern of illness. Social history is very important, particularly with regard to the environmental tobacco smoke, cooking pattern, and the house, which may make the children more prone to respiratory infections. You also have to take a detailed symptom-wise history of the respiratory system, elaborating each of the symptoms like cough, fever, respiratory distress, or any abnormal sounds. But specific importance is also given to other systemic manifestations with respiratory system, that is multi-system in one. The respiratory tract and the gastrointestinal tract are closely associated with each other, so you should take history relevant to other system as well. So as you dig deep, you get gold. So this is the old proverb which everyone we've been quite familiar with. So in the case of recurrent pneumonia, the same proverb holds good. So dig deep, you get more information. You have to be like a Sherlock Holmes, who have to get into the details of every problem to arrive at a diagnosis. So detailing the details, this is what we call as detailing the details. See, with you child would usually have to have multiple admissions, and they will come with a huge file. To simply put into a nutshell, you have to take the age of the child of the each admissions, the duration of the illness, fever, cough, and whether respiratory distress was there, other systemic involvement, what sort of ventilation modality was given. Once we have written this, then you go to the investigations. What are the basic blood counts, differential count, absolute neutrophil count, and absolute lymphocyte count, CRP or the procalcitonin if it is done, chest X-ray, draw the X-ray serially, and other images like CT MRI if it is done. What was the duration of the antibiotics given or any complications of the pneumonia which had occurred? Any other additional tests like immunoglobulin profile, flexible bronchoscopy, all these things has to be charted in this. So you can, this is a very important tool to find at arrive at a diagnosis. Many of the times the conclusion can be made with history examination and with this detailing itself. So once we take the details, when you go to the examination, you have to have some clue. What are the basic clues which will help to arrive at a diagnosis? Whenever there is polyphonic recurrent wheeze, it is just probably an asthma alone. When you have a monophonic recurrent wheeze, it indicates an airway malacia, most probably a bronchomalacia. The nature of the cough, whether it is a dry cough, wet cough, moist or a metallic cough, also gives a very important clue to our diagnosis. Whenever you have cyanosis with clubbing, you have to mainly rule out congenital heart disease and cyanotic congenital heart disease and chronic suppurative lung diseases. Neuromuscular problems like spinal muscular atrophies and Duchenne's muscular dystrophies and scoliosis can have restrictive problems. Bone abnormalities, children with CNS related issues can have hypo or hypertonia, and they can have a lot of oromotor problems leading to oropharyngeal incoordination and cause of aspirations and pneumonia. Chest wall abnormalities give us indication of the chronicity of the problem and the restrictive nature of the problem. Don't never forget to do an ENT examination because it may give a lot of clue. A polyp in the case of cystic fibrosis, chronic suppurative otitis media in Bruton's A gamma globulinemia, and a smaller and absent tonsils in hypogammaglobulinemia syndromes. Never forget to plot the growth chart and to see for dysmorphism. And to conclude our examination, it is always mandatory to examine the palate to look for a posterior cleft palate, which is one of the hidden causes of recurrent aspiration pneumonias leading to recurrent pneumonias. And always don't forget to examine the tongue for the tone as well as the skin to see for markers of eczema or any abscesses which was drained previously. Now, when will you consider a recurrent pneumonia to be significant, and what are the clues to investigate them further? Whenever you have a multi-system involvement, whenever you have an infection which is severe, which is persisting, which is unusual, and it is recurrent. Unusual means the organism involved. When there is failure to thrive. We call it as same lobe every time. Whenever you have each pneumonia is affecting only one particular lobe, think of an anatomical problem. When you have a problem of multilobar involvement, different lobes are being involved every time, then you think of a physiological problem, like a problem of mucociliary clearance or immunodeficiency, which may be local or a systemic immunodeficiency. Early age of onset is very, very important with regards to congenital lung abnormalities of the parenchyma. Always keep in mind asthma, TB, and foreign body, which can mimic any infection. Chronic upper respiratory tract infection from the first month of age should lead to a clue of an early onset problem with mucociliary clearance. Family history of lung disease or death is a very important factor. Persistent abnormal clinical examination finding or radiological finding with or without clubbing is also a very important clue to investigate further. So with these small clues, we will go with the case scenarios. So we will start first with case scenario 1. See, this is a 5-year-old boy who has had recurrent admissions. He has 4 admissions in total. The main reason for admissions has been fever, cough. Cough is the main factor, and fast breathing. His growth and development is normal. There are no obvious clues on examination. No other clues on history. However, history revealed that the child is a asthmatic. He fit into the qualifiers for asthma. That he had recurrent cough, wheeze, and breathlessness nocturnal episodes. Now we have to detail the details. See, we have found out that all his admissions, his main problem is cough rather than fever. He has distress, he has been nebulized, other systems are not involved, and he's never been intubated. So we find out that he has a problem, not major of an infection, but more of a, whenever cough is a predominant finding, it indicates an airway involvement. Which is confirmed here, like his counts and his admission CRPs are very, very normal. So this indicates that he does not have any, this boy has an airway problem, does not have a significant infection. So you find out what to do at each case. We can have to apply this rule of 4. Does the child have a upper tract involvement or a lower tract? Is it pneumonia really? Pneumonia is high grade fever with elevated counts with a patch in the X-ray. Bronchopneumonia is not equivalent to shadowing. It will not be classified under recurrent pneumonias. Recurrent infiltrates can be taken significantly. Recurrent pneumonitis or a patch is very significant. It has to be taken seriously. Third question is there involvement of other organ systems? And last point is, where in the lung, which lobe is involved? So these 4 questions are very, very important. So with regards to this child, what you can see is this child has no significant patch. So the final diagnosis was recurrent wheeze and no recurrent pneumonia. This was a case of an underappreciated asthma. Or then why didn't it have fever? There is an entity known as hypersecretory asthma. Whenever there is increased tracheobronchial secretions, they cause atelectasis of the right mid zone or infiltrates in the right mid or lower zone, which can mimic like an infection. That is why the counts had not been increased in this child. So the most common 30% of children referred for recurrent pneumonia were diagnosed to have underappreciated asthma. So this is case 1. So we have to very well remember that underappreciated asthma is always should be taken into account. Next, we'll move on to an case scenario 2. This is an 8-year-old boy who's admitted. He has no comorbids. This boy has a fever of 7 days duration with cough and fast breathing. Similar episode 5 months before. He was febrile toxic, growth was minimally affected. He had a bronchial breathing in the right infrascapular region. So we have a problem here of a consolidation because of the bronchial breathing and the symptoms. So we proceeded to take an X-ray for this child. This is an alarming shadow here, which with a cystic-like lesion, homogeneous mass-like lesion. We proceeded to take a CT for this child, which resulted in a lung abscess. The CT showed a lung abscess. So detailing the details, this is not, X-ray does not show a classical finding, but we see like a circumscribed lesion with fluid. Now we probed into the history. This boy was admitted first at 7.5 years of age and then at 8 years. His main problem was not cough, but was fast breathing and fever. So and other systems were not involved. His counts on board the admission was 25,000, 20,000 with neutrophilic leukocytosis. CRP was significantly elevated. Duration of IV requirement were 3 weeks. He had 2 lung abscesses. Both the X-ray showed similar pattern. So diagnosis of lung abscess was entertained. Now what was missed in this child? Where did we go wrong? We did an immunoglobulin profile which was normal. One issue with this child was the child was lost for follow-up after the initial 6 weeks of treatment in the first admission. So when we probed the history, it all began with the history. To draw a long story short, the mother told that in the last trimester, antenatal scan was done which showed an echogenic multiple cysts seen in the right lung suggestive of macrocystic congenital cystadenomatous malformation. In fact, it was such significant that they had been advised follow up weekly once, and they had also given the option of a cystoamniotic shunt if there was worsening of this. So this is a case of infected cecam presenting as an lung abscess. So this is an infected cecam lung abscess. So the take home point here, this shows only the upper lobe involvement of macrocystic lesions in the upper lobe. However, the sections of the middle and lower lobe also showed cysts like this. So it was an involvement of the whole of the right lobe. This boy was operated and the abscess settled. Always ask for antenatal history. CT findings are more pronounced in the absence of infection. Remember that when you have 2 lung abscesses, it is mandatory that an interval CT scan should have been taken in this child. Same lobe every time, think of anatomy. So this boy had same lobe involvement every time, think of an anatomical problem. The final conclusion was an infected cecam presenting as recurrent pneumonia. So with this, we move on to the third case. There's another interesting child, a 9 months old infant who had a normal birth history. Child had 2 admissions in 6 months with fever, cough and fast breathing. Fever was a predominant complaint. Fast breathing requiring 2 admissions. Thriving well infant, no other clues. This child also bronchial breathing in the right infraclavicular area. So probably some upper lobe involvement. We proceeded to take an X-ray which showed a right upper lobe collapse with a consolidation. There is a linear demarcation here, so it's a collapse upper lobe with a consolidation. So both the past 2 admissions were detailed. One at 6 months, one at 9 months. Fever was the predominant complaint. There was no significant hypoxia. The counts were elevated. There was neutrophilic leukocytosis. So it fits into a picture of recurrent upper lobe consolidation. What the previous case taught us was, whenever there is recurrent unilobar involvement, think of an anatomical problem. So we wanted a small child, in order to avoid radiation, we proceed with a bronchoscopy first in this child, and to our surprise, what did we find? So as we move towards the carena, this is the carena. I will just pause here. So this is the carena. This, what you see here, is what is known as a tracheal bronchus. There is a division of the carena into the right and left main bronchus, but there is an additional opening here known as an tracheal bronchus. So this is what is known as tracheal bronchus, which is seen more clearly now. So the final diagnosis here was a recurrent pneumonia, same lobe every time, tracheal bronchus. So why is this picture put here? These studies have shown that anatomical models of pig have led to the fact that pigs normally have tracheal bronchus. For example, in bronchoscopic training, when we learn bronchoscopy on live animals like pigs, tracheal bronchus is a normal finding. So what is this tracheal bronchus and what are the types? So you have the bifurcation of the carina under right main bronchus, left main bronchus. This is the upper lobe has apical, anterior and posterior segment. Sometimes the apical segment can arise prior itself. So this is another type known as a displaced type of tracheal bronchus. Sometimes there may be an additional bronchus, supernumerary type. This was in our case. And for pigs, they have the upper lobe bronchus itself arises much before the carina itself. So this is called pig bronchus. So we have a case of recurrent pneumonia due to an anatomical problem, that is tracheal bronchus. So moving with this, we'll move to the fourth case. So we have seen a normal child with asthma, a child with two anatomical problems, that is infected cecam presenting as lung abscess, and another child with a tracheal bronchus. So this is case 4. So this is a 7-year-old boy who is presented with cough, fever, and distress. You can make a note here, cough is a predominant finding. So think of an airway problem. Treated for pneumonia 6 months ago. So you have an airway problem with a pneumonia. He was febrile with minimal hypoxia. He was referred for admission. Growth development was normal. He had little air entry was reduced in the right axilla. Otherwise a well child. When the history was probed, the mother told that he fit into a moderate persistent asthma. We can make a conclusion with that, with a strong familial history. He was admitted once at 6.5 years of age and 7 years of age. Duration was for 5 days. Cough was a predominant finding. Fever was minimal. There was distress but no significant hypoxia. So with this, what we did, we went examined the counts. Both the counts were normal. When the counts are less than 15,000, there is no role for calling it as a neutrophilic involvement. So counts are less than 15,000, though there is no infection. CRP was minimally elevated. Anything less than 30 can be taken as less severe. Both times he had a mid-zone involvement. So duration of antibodies given was for 4 or 5 days. He was well, and in fact a bronchoscopy was done in an outside hospital, which was normal. The X-ray of this boy when probed showed that, see, whenever you have an obliteration of the right heart border, it indicates that it is a middle lobe involvement. There is obliteration of the middle lobe here. There is a segmental atelectasis. Surprisingly, this boy's chest, usually radiological clearance takes place at least a week. This boy's X-ray resolved very, very quickly. So that means what? The more than an infection, there was atelectasis. So this was a middle lobe atelectasis, what we commonly known as the Brock syndrome. Brock syndrome is right middle lobe atelectasis, which can be caused by uncontrolled asthma. The radiological clearance are usually was quicker in both the admissions, which led to fact that indicating that it was not an infection but more of an atelectasis. What next? Bronchoscopy was done, it was normal. A PFT showed a significant obstruction for this boy. Just to conclude this case, a note on the right middle lobe syndrome. We need to know a little bit about the anatomy here. You see here, the trachea bifurcates the carina into the right main bronchus and left main bronchus. We have the upper lobe which is taking up here, apical anterior posterior segments. This is the bronchus intermedius in brown. The green color marked here is your middle lobe, which has your medial and lateral segments. Because of the long course of the middle lobe, it has a long course. You see the angle, it takes off at a very acute angle. It takes off long course, acute angle takeoff, and you see the middle lobe is the only part of the lung which does not have collateral ventilation with the other lobes. Because of all these findings, you have a tendency for secretions to accumulate in the middle lobe. However, middle lobe syndrome, you have to entertain 3 diagnoses: asthma, TB, foreign body. Infectious cause of middle lobe syndrome is always going to be tuberculosis in a developing country like us. The middle lobe syndrome can be an obstructive cause. It can also be a non-obstructive cause. So we have seen all the cases we have seen here are children with recurrent unilobar involvement. So how will you approach a case of recurrent unilobar involvement? It is a localized disease. It can be an first thing is it can be a congenital lung lesion. It can be a cyst in the lung. It can be an emphysema. It can be a cecam, which as we discussed, or it can be a sequestrations. So these are all the congenital or lung parenchymal problems. The current terminology is known as congenital thoracic malformations. You can have an endobronchial involvement for a localized cause. What is the endobronchial involvement? It can be a foreign body. Narrowed airways can be presenting either as an something is pushing from the externally, which might be a node, a vessel, or a tumor. So an extrinsic compression can cause a narrowed airways. Next one, whenever something is problematic in the bronchial wall, that is bronchomalacia or a stricture, then you can have a localized problem. Then finally, when you go into the bronchus itself, endobronchial environment, it can be a tumor, a carcinoid, it can be a foreign body, or a tuberculosis. Last causes are focal bronchiectasis. You can have focal bronchomalicias. An upper lobe alone, right upper lobe alone, can have a bronchomalacia that can lead to recurrent upper lobe consolidation. So localized disease can be due to narrowed airways. The narrowed airways can be due to an extrinsic problem, wall problem, or an endobronchial problem. Commonest is congenital lung malformations, and always focal bronchiectasis should always be considered. Focal bronchiectasis. So with this, we conclude an approach to lobar unilobar involvement. Same lobe, think of anatomy and investigate. History and physical examination is primary. Bronchoscopy with BAL is the primary modality. If inconclusive, you can go for a CT with a contrast. If you have a vascular anomaly, you can go for a MR angiography or a CT pulmonary angiography. If still you are inconclusive, the last step is when you have to consider a lymph node biopsy, or a mediastinoscopy, and you have to consider a surgical excision. So you go for a semi-invasive procedure like a bronchoscopy, then for a radiation involving procedure like CT. If still it is unconclusive, then you can proceed for a lymph node biopsy, mediastinoscopy, and a surgical excision with the help of a rigid scopus. So this is the approach to a case of a recurrent unilobar pneumonia. So we'll go to the next section of cases. This is a 10-month-old child who has been admitted for cough, fast breathing, and fever. One important history is the mother always gives a history that the child choked during feeding and the child coughed during feeding. There is no other significant history. Child was having failure to thrive. There was bilateral crackles, and feeding of the child was examined. It is mandatory that any child with recurrent pneumonia, the feeding has to be examined. Water, if the child is old enough, or if the child, you can give a cup of water to the child and see how the child swallows. This simple examination yields a lot of very important findings, which might help to give us a clue as to find out the reason for the choking or the recurrent pneumonia. So with this, what is your diagnosis? So there is a problem, probably some communication with the gastrointestinal tract and the respiratory tract. So when we went to the details, all the children at 5 months, 7 months, all the 3 admissions, there was cough with feeding as a predominant complaint. The fever was not a significant component here. There was only minimal hypoxia on 1 admission. There was non-invasive ventilation on 1 admission. So counts were not significantly, there was no significant elevation. All the counts were less than 15,000. Now, duration of stay was 5 days. So when we proceeded to examine the chest x-rays, what we found out was, this is the initial first x-ray taken, which showed a right upper zone, mid zone, and a lower zone involvement. Multi-lobar infiltrates could be the description of this x-ray. Second admission showed up mid and lower zone particularly. So these are all aspiration segments. Mid and lower zones particularly are aspiration segments. So with the background of cough during feeding, we have a clue that this is a case of multi-lobar recurrent infiltrates. So we proceeded with the bronchoscopy, and what you see here is nothing but an tracheo-esophageal fistula. This is arising just before the bifurcation of the carina. So this is a tracheocecal fistula and H type of fistula which has a delayed presentation. Always take a feeding history, do a feeding examination. FOB facilities, if available, are the first investigation of choice rather than going for a barium swallow or in barium esophagogram. This H-type fistula presents usually outside the newborn period, and always be aware of aspiration segments. Commonest causes of recurrent multilobar infiltrates are aspiration pneumonias. Other causes may be GRD, a laryngotracheal cleft. These are all the causes of recurrent multilobar infiltrates due to aspiration. So this is a case of recurrent multilobar pneumonia presenting as H-type fistula. Moving on to case 6. This is a 7-year-old boy who presented with fever, cough and fast breathing. He had 5 prior admissions. There was growth failure, pus from both the ears, grade 1 clubbing, bronchial breathing in the right axilla. This child has a growth failure problem with chronic discharging ears, clubbing. He has a suppurative lung disease. All the 3 admissions were examined, 5 years, 6 years, 7 years. The duration was around 10 to 7 days. Fever was a predominant finding here. There was distress on all the admissions and no significant hypoxia. And all of them involved a upper tract involvement, for example, acute suppurative otitis media. Examining his counts, all these counts showed an neutrophilic leukocytosis. The last one was a more indolent infection because there was neutropenia with leukopenia with neutrophilic involvement with elevated CRP. This usually happens in a very severe bacterial infection like a PVL producing organism or a staph pneumonia. All his CRPs were more than 100. When we proceeded to examine his X-rays, so we have a recurrent pneumonia problem here. When we proceeded to examine his X-rays, this is a serial X-rays. First X-ray is showing a right, left upper, mid and lower zone involvement. The other X-rays, second X-ray was showing a right, mid and lower zone involvement. Third X-ray was showing bilateral right mid zone and a left lingular involvement. The final X-ray was showing a right upper lobe involvement. So you have a child with multilobar consolidation affecting different lobes. Different lobes every time think of local systemic immunity problems. So how to conclude this case? How did we arrive at a diagnosis? This child's IgA was found to be very low. IgM also was found to be very low. We proceeded to do a flow cytometry which showed a CD19 marker was very, very low, was 0.06%. HIV was negative. Sweat chloride was negative. So this is a case of Bruton's A gamma globulinemia. Genetic mutation studies has also been sent for this child, which came out to be positive. The BTK gene was positive here. However, whenever we conclude as PID, always rule out HIV. Multilobar recurrent presenting as Bruton's pneumonia, boy with recurrent pneumonia, with CSOM, recurrent ASOM, multilobar pneumonia. The small clue is whenever you have a serum globulin less than 1.8, it is a clue for an antibody deficiency. So when you see your counts with this picture, you can see here for your serum globulin levels. If it is less than 1.8 gram per DL, then you proceed to do an immunoglobulin profile and then your flow cytometry. Now, what are the common primary immunodeficiencies which are associated with recurrent multilobar pneumonia? Antibody deficiencies like common variable immunodeficiency, Bruton's A gamma globulinemia, selective antibody deficiencies are involved. Phagocytic disorders like chronic granulomatous disease and leukocyte adhesion defects can also present. They usually have recurrent multifocal deep-seated abscesses. Third thing is disorders of combined immunodeficiencies that can be hyper IgM syndrome due to class switching CD40 ligand deficiency and children with severe combined immunodeficiencies. These are the children with PIDs who can present with recurrent pneumonias. This is the Jeffrey model classification, which is very, very important, as all of you would have been familiar with this. Whenever you have any of these features, you go on to investigate primary immunodeficiency. But as a rule, exclude HIV first, then proceed based on your findings. 4 or more newer infections, 2 or more serious sinus infections, 2 or more pneumonias, recurrent deep-seated abscesses, persistent oral thrush, always needing intravenous antibiotics to clear infections, or 2 or more deep-seated infections requiring including septicemia and a family history of primary immunodeficiency. This is the Jeffrey model classification for PAD, clue to identify a PAD. Moving on to the last few case scenarios. We have a 7-year-old boy, 6-year-old boy, who presented with recurrent LRTA, chronic moist cough. The onset of this moist cough was from first month of life. He had an NICU admission for respiratory distress. Growth was minimally affected. He had grade 1 clubbing with serious discharge with mild tachypnea and bilateral diffuse Krebs. So the clue here is chronic moist cough from infancy, NICU admission. The onset of cough was from NICU. Remember, he also has a suppurative lung disease, grade 1 clubbing. Whenever you have an upper respiratory involvement with chronic suppurative lung disease, before thinking of with a chronic moist cough, always think of primary ciliary dyskinesia. This is his previous admissions. He was admitted once at 1 year and 4 years of age. He had multiple admissions, but we were able to trace only 2 of his details. The admission showed that he had significant running nose and serious discharge from first year of life, from infancy. His counts were elevated but marginally, 15 to 17,000 with neutrophilic predominance. CRP also was elevated. He always required IV antibiotics to clear his infections. This is his chest X-ray, which shows both the right heart border and the left heart border is obscured. Whenever you have obscuring of both the heart borders, it means there is middle lobe involvement, right middle lobe involvement and left middle lobe, that is the left lingular involvement. The second admission showed only a right lower lobe involvement. So he has a multilobar in consolidation. Now, what was already done for this boy? His IG profile was normal. His HIV was normal. Sweat chloride was normal. A ball was done outside, which grew H influenza. So how should we proceed now? Very, very important to remember that any child with chronic moist cough presenting with upper respiratory tract involvement with lower tract involvement, you have to do what is known as a Picard score, which I will be discussing in the next slide. Picard score is nothing but primary ciliary dyskinesia rule is the acronym. Picard score for this child was 9. We proceeded to an HRCT which showed bilateral middle lobe bronchiectasis. So what is this Picard score now? Whenever you have a patient with daily wet cough which started in infancy, then only you have to proceed to put this score. If the boy is born full term, then you have 2 points. If he had neonatal admissions, you have 2 points. If you was admitted with pneumonia, then you have again 2 points. Situs abnormality, dextrocardia, you have it is significant involvement, which shows 4 points here. If he has a congenital defect, you have provided 2 points. And if the patient has perineal rhinitis or hearing problems, you give a point each. 50% of children with PCD present with dextrocardia, but the other 50% do not present with dextrocardia. It is an unrecognized problem in our country. When a score more than 10 is significant, a score more than 7 with this background should be investigated further. This boy had a score of 8. So chronic wet cough this boy had. He had a Picard score which was positive. The first line screening test is a nasal nitric oxide. Whenever there is infection or inflammation, nasal nitric oxide levels are elevated. In a problem with mucociliary clearance, the nasal NO is less. So the first clue is when you do a nasal nitric oxide which is less than 77 nanoliters, then you think of PCD. Next, you proceed to what is known as a HSVM. HSVM is nothing but what is known as high-speed video microscopy to find out the ciliary beat frequency, motility, and the variability and the pattern of the beat. So this boy, our case, had a nasal NO of only 20. We also proceeded to do a high-speed video microscopy. If the patient is affordable, you can do mutation if possible. There are mutations which are specific for the inner dynamics and for the outer dynamics. However, if you have a Picator score negative, you should consider an alternate diagnosis. There is no specific rule of how to proceed, but this is the general algorithm approach in a child with chronic wet cough. And you can remember that PCD most of the times tend to involve the middle or the lower lobe. So this is the picture. It's not our child. We don't have the picture. It is currently being done in Coimbatore by pediatric pulmonologist. The high-speed video microscopy will be shown in the next picture. This is the nasal NO. This is done by chemiluminescence method. You have a nasal thermistor which measures. Why the starts to blow is to achieve velum closure. So this is a child with cilia. You see the angulation, rotation, and the ciliary frequency movements, which is very nicely seen here. However, in children, abnormal cilia, you see the sluggishness, the to and fro motion is altered here. So our child had a picture which was similar to an abnormal cilia. Abnormal ciliary motility, as you see on the picture on the right side. So the conclusion was recurrent multilobar pneumonia, lower lobe, middle lobe bronchiectasis with primary ciliary dyskinesia. Last few case scenarios. This is scenario 8. You have a 4-year-old girl who presented with 3 prior admissions. All the 3 admissions, there was fever, cough, and fast breathing. Birth and development was normal. She was failing to thrive. There was bronchial breathing in the left infraclavicular region. She had a protuberant abdomen. Now, she was admitted once at 1 year of age and another at 2 years of age. The duration was for 4 to 5 days. Both the investigations, admissions showed neutrophilic leukocytosis. One admission had a right upper lobe consolidation, other admission had a left upper lobe consolidation. Important clue is both the admissions showed hyponatremia, minimal hyponatremia. 130 was the sodium for this child. First admission was showing an upper lobe consolidation. Next admission was a left upper lobe consolidation. You have a right upper lobe consolidation, left upper lobe consolidation. When we probed the history, mother told that his abdominal distension was significant, it was gradually progressing, and he had constipation, rectal prolapse, and was passing greasy stools. So he was already investigated outside with immunoglobulin profile which was normal, HIV was normal, and echo was also normal. What did we do now? He had a clinical phenotype which was very particular and big and fitting into a cystic fibrosis. We did a sweat flow rate which was more than 60 milliequivalents, which was also repeated 4 weeks later. This is the aquagenic skin test which we also did for him prior to doing the sweat flow rate, which was 3 minutes. I would explain what is the aquagenic skin test. BAL was done for him in view of the recurrent pneumonia which grew Pseudomonas. Stool fat was abundant. Stool fecal elastase is very costly. So stool fat quantitatively can give a very rough estimate of the pancreatic malabsorption. So we have a clinical phenotype of cystic fibrosis here. Whenever you have a phenotype or a family history or a positive immune reactive trypsinogen in the newborn screen, then you have to proceed with sweat chloride. When you have 2 abnormal sweat chloride, then it is diagnostic. But since some mutations can have drugs now, you always have to do mutation analysis. 2 recognizable CF disease-causing mutations have to be identified. Since the mutations panel are expensive, if someone is not have only a 2 abnormal sweat chloride with a phenotype, you can take it as clinically significant CF and follow up the child and treat the child as cystic fibrosis. However, mutation, if possible, should always be done. Now, the new kid on the block is aquagenic skin wrinkling test. The final diagnosis for this child was a recurrent multilobar pneumonia CF phenotype, and this child mutation was delta F508. So what is this aquagenic skin test? This is called what is known as a hand in the bucket sign. This is a simple bedside test, screening test But however, this test cannot replace sweat chloride. What we do here, we ask the patient's affected child to immerse the hand, one of the hand in water. For example, this child's left hand was immersed in water, the other hand is kept outside. The water should be a reverse osmosis RO water. After each 1 minute, the hand should be taken out and examined for 3 seconds and should be photographed by a second observer. At the end of the 3 minutes, if wrinkling develops at the fingertips, then you call it as an aquagenic skin test positive. For normal persons, the aquagenic skin wrinkling time is 10 to 11 minutes. For children with cystic fibrosis, the aquagenic skin time is positive at 3 minutes. This is the picture taken at 1 minute and this is taken at 3 minutes. For this child, this is positive even at the first minute itself. This has a sensitivity and specificity of 70% is the sensitivity. The specificity of this test is 57%. This cannot replace sweat chloride, but in a limited resource setting, prior to doing a sweat chloride test, you can do if your phenotype persists with CF, you can do a aquagenic skin test. This is called the hand in the bucket sign. This was devised and lot of studies has been done by Dr. Professor S.K. Kabra in AIIMS, and the study was published in 2019. So moving on to the last case. This is a 2-year-old boy. This is a very interesting case who was admitted with recurrent respiratory tract infections, fever, cough and fast breathing for 5 days duration. There is always fever, cough was predominant finding in fast breathing. He was thriving fairly okay. There was no clues on examination. The distress that was present on every admission, there was a short systolic murmur in the pulmonary area. So when we move to the details, this boy was previously admitted at 1 year, 1.5 years and 2 years. Duration of admission was 7 days. The first admission, he had a swine flu with secondary bacterial pneumonia, required NIV, high flow nasal cannula. Second admission was at 1.5 years, no NIV, he had no hypoxia. Third admission was at 2 years, always had fever, cough was predominant. You also had some wheezing features, fit into an under 5 wheezer and was started on inhalers, but he continued to have these symptoms. There was significant finding of only neutrophilic leukocytosis only on one admission. The other admissions, the counts were normal. CRPs were not significantly elevated, and all his admissions were for around 4 to 5 days. His IG profile was normal. One echo was done outside was also normal. This was his X-ray, just showing a right mid and lower zone infiltrates. There was no significant patch. All his X-rays were showing a similar pattern. Looking carefully at this X-ray, there was some radiological clearance definitely between the two X-rays. Because his profile was normal and his echo was normal. Now, how did we proceed about this child? In view of the murmur, our radiologist suggested that we proceed with another echo. And what we found out that there was a communication between the atria. There was a atrial septal defect. The atrial septal defect here is the sinus venosus type of defect. An important take-home point here is whenever you have a sinus venosus type of ASD, always look for an abnormal pulmonary venous drainage, which may be PAPVC or a TAPVC. This child has presented later. He was well for a year. So probably when the CTPA was done, he showed a partial anomalous pulmonary venous connection, sinus venosus type of ASD. This was in the famous words of Dr. Andrew Bush, the famous American pulmonologist. This is multilobar recurrent infiltrates known as recurrent cardiac pulmonary edema or cardiac edema manifesting as infiltrates, mimicking as pneumonia. And whenever you have PAPVC, always look for the SWOT. So our child did not have this picture. I have just put this picture for completion purpose. Whenever you have, take home point is whenever you have recurrent left right, whenever you have a left right shunt with right sided infiltrates, which are multilobar with a murmur, trace the child previous x-rays. If your echo shows a sinus venosus ASD, always do a CTPA to look for a abnormal venous communication. Whenever you have an abnormal venous communication, your CTPA, your X-ray for this is a different child showed a small volume lung. Whenever you have a small volume lung with a partial anomalous drainage with an ASD or without an ASD, you will think of Scimitar syndrome. So this was a case of PAPUC sinus venosus ASD. This child did not have, however, Scimitar syndrome because the volume was normal. Volume of the lung was normal. So how will you approach a child with recurrent multilobar pneumonia? Check the immunity status. If the immunity is a problem, baseline is a serum globulin. You have clues in your absolute lymphocyte count and a neutrophil count, ANC and ALC. Always rule out HIV. After doing a globulin levels, do a immunoglobulin profile known as a GAME profile, GAME, and then do a flow cytometry if required. If your immunity is normal, what you would do is you will look for mucociliary problems. That is, you have only two mucociliary clearance problems, that is cystic fibrosis and primary ciliary dyskinesia. So you investigate specifically for them. If you have aspiration, you see whether it's a GRD or a fistula or a laryngotracheal problem or an oromotor problem due to a neuromotor incoordination. You can do a barium swallow or an esophagogram and esophageal pH studies, and always rule out congenital heart disease. Structural problems like bronchomalacia can also cause multilobar pneumonias. Post-infective causes like measles, pertussis, tuberculosis can also present as recurrent multilobar pneumonia. Always remember neuromuscular problems. Children with neuromuscular problems like spinal muscular atrophy and Duchenne's muscular dystrophy can have recurrent pneumonias. I have purposefully omitted pulmonary hemorrhage syndromes and connective tissue disorders. However, there are all rare possibilities. They can also come and present as recurrent multilobar pneumonias. CT chest and fiber optic bronchoscopy is always can be done if it is inconclusive with this approach, and whenever you have any complications, and whenever FOB is a very good investigative tool, scopy, because you can see the anatomy and also do a bronchoscopic lavage. To conclude the last few slides, I would just like to mention the rule of exceptions. Whatever recommendations we have said is fine, but you have to always remember the rule of exceptions. In general, same lobe every time think of anatomy. Different lobe every time think of a mucociliary, local systemic immunity, or a neuromuscular cardiac problem. However, the studies have found that 80% of children with antibodies, that is humoral deficiencies, have pneumonia in the same lobe, and 20% with structural problems have had multilobar pneumonias. This is a rule of exception. Just always you have to have it in mind. To conclude, I would specifically have 10 take-home points which I would like to tell. You have to find out whether really the pneumonia is recurrent. Classify whether it is a unilobar or a multilobar problem. Need not do all investigations, do targeted investigations. History is foremost. Give importance to feeding pattern. Also include feeding examination as part of your routine systemic examination. Always rule out asthma. Avoid doing CT in an acute setting unless you think of an alternate diagnosis like neoplasm or a lung abscess. Always evaluate atypical wheezers. Don't forget the past. I mean here the past history, and focus also, in addition to the respiratory tract, the other systems, and particularly the close friend of the respiratory tract, the gastrointestinal tract. Thanks one and all, and hope I would like to take any questions. We're open to taking questions. The next, the time is 1 o'clock now. We can have a question answers like for 5 minutes. We can discuss about any questions if anyone has had. A very important question has been asked by Dr. Kamakalan sir. How far it is important to identify the organism in recurrent pneumonias? Very, very important to identify an organism, because identification of an organism gives us a clue. For example, in case of cystic fibrosis, you can have a pseudomonas. It can be a primary ciliary dyskinesia where you can have recurrent Haemophilus influenza infections. You can have CME positivity infections in severe combined immunodeficiencies. And whenever a bronchoscopy is done, it is mandatory that recurrent pneumonias, we in the presence of an acute setting infection, if the child is having a pneumonia, if it is a multilobar pneumonia, then to find out an etiology of the pneumonia, it is very mandatory that we do a bronchoscopy with a lavage. With regards to a recurrent unilobar involvement, before proceeding to CT, if we are not thinking of a pulmonary malformation, if you are thinking of an airway malformations, like a tracheal bronchus, you can do a FOB. In such situations, when there is unilobar involvement, BAL is generally not required. Multilobar involvement, definitely BAL has a major role to play. Is there any...
Congrats on a good presentation, Dr. Vivek. I would like to ask you, is electron microscopic facilities available in Chennai to study the beat frequency as well as the cilia in a suspected PID?
Primary ciliary dyskinesia.
Yeah, PCD.
Currently, there is not available here, sir. What we used to do in ICH, where I did my training, is we had 2 cases in the last 1 year. So it is currently being done in Coimbatore by Dr. Anthony, who has got the machine, and he is doing, and he has been researching a lot on primary ciliary dyskinesia children. That is a place where we do nasal nitric oxide as well as high-speed video motion microscopy. So currently in Chennai, we don't have facilities to do both. So we are referring children to Coimbatore to get these 2 investigations to conclude and get these 2 investigations done.
Thank you. Thank you for this information.
Important choosing that, Vivek.
Yes, ma'am.
Yeah, choosing the antibiotic, is it the general consensus for the recurrent pneumonias, or you go step up the, the antibiotic regimen?
Very pertinent question, sir, which you have asked. For example, if when we are dealing with a problem of a local problem, that is single lobe involvement, when you are thinking of only on malformations, then our routine management with amoxiclav or ceftriaxone for hospitalized children would do. But however, if they turn into abscesses, we would definitely need to add on staph coverage and anaerobic coverage. So clindamycin might be an option. But very pertinent is when we are dealing with, for example, multilobar pneumonias with aspiration, amoxiclav is the drug of choice, sir. However, for children with cystic fibrosis or immunodeficiency, gram-negative coverage should be given priorities. So a piperacillin tazobactam or a ceftriaxone sulbactam would be an initial choice for a cystic fibrosis child who comes sick. And when you are suspecting the phenotype matches, then you directly go to an higher antibiotics when you escalate directly in the setting of an immunodeficiency or a mucociliary problem like CF or primary ciliary dyskinesia.
Thank you.
Important. Another question has been asked: is there any precautions to avoid recurrence? Very important question is how to avoid recurrence. There are some unfortunate groups of children, like children who are born preterm, children who are exposed to environmental tobacco smoke, children who have had bronchopulmonary dysplasias and chronic lung disease, and children who have an environment which is smoke filled. For example, the cooking environment or the environmental smoke exposure. All these children, their studies have found that though they have recurrent infections, but when we investigate, nothing significant has been found in them. So you remove the triggers, then automatically these children tend to settle down with time.
Any study regarding the occupational pneumonia occurring as the recurrent pneumonias?
There are very minimal studies in the pediatric age groups. Adult population with silicosis and vicinosis are definitely being published. However, eosinophilic pneumonias with significant environmental trigger, what we call as hypereosinophilic syndromes and acute or chronic eosinophilic pneumonias, they can also present as recurrent pneumonias. The current classification for recurrent multilobar pneumonia also includes eosinophilic pneumonias, where the environmental trigger plays an important role. Hypersensitivity pneumonitis. Few children from Tirupur districts and other things where the cotton exposure have been there, they have presented with such scenarios. They will also have to consider hypersensitive pneumonitis, eosinophilic pneumonias in such children, sir. Definitely.
Thank you.
Thank you. Thank you. A question has been asked by Dr. Nayan. When to suspect cryptogenic organizing pneumonia in oxygen-dependent infants? Cryptogenic organizing pneumonia, current what is known as COP, is nothing but bronchiolitis obliterans. When you don't have a usual course of bronchiolitis, for example, a child has had bronchiolitis, you usually tend to the cough and the respiratory symptoms should settle down in 3 to 4 weeks time. The acute phase is between 4 to 7 days. Then after the 8th, 9th day, the child should settle down, and between the 20th to 30th day, all the symptoms should resolve. When you have for more than 8 to 12 weeks, clinical, radiological, and the V's persist, when they develop fixed airway obstruction and when they are oxygen dependent, then when the time period is more than 8 to 12 weeks, still the bronchiolitis symptoms have worsened and has exacerbated, then you will think of, with alveolar shadows on the X-rays, homogeneous opacities, then you will think of cryptogenic organizing pneumonia, and they are usually oxygen dependent. You will have persisting crepitations, these with hypoxia in such children. In a way to approach it, this is there are many studies which have shown that some of these children tend to improve with time, but however, some can have a very rapid fulminating course, being oxygen dependent. Sometimes steroids may or may not work. The generally home oxygen and following up these children is the recommendations which we give. However, they can have frequent exacerbations requiring hospitalizations. So home oxygen, steroids for some children, and currently they have also, as azithromycin has an important role. Studies are there where because of its immunomodulatory action, where azithromycin can also be added to the regimen. Thank you. Thank you. If there are no more questions, thank you all for thank you all for attending to this lecture and giving your the feedback was very nice, and a lot of important and pertinent questions which are being asked. Thanks again. Have a good day. If anyone has any more queries, I'm willing to take any more questions if you feel that it is required. Thank you.